Okay, Alessandro, we can start.
Hey, good evening, everyone. It's such a great pleasure, a great honor of being with you this evening, talking with something very, very interesting, something that everyone faces in everyday practice in our cath lab in TAVI patients. It is a great pleasure to welcome to these new episodes of EIJ On Air. My great friend, young but a very clever guy, Francesco. Thanks so much for being with us.
Hi, Alessandro. Thank you for the opportunity to share the results of this study.
Francesco Bendandi will present us a paper. He is the first author of such a very interesting paper that has been published very recently on urointervention. The title of the paper is Development and Validation of the D-PACE scoring system to predict delayed high-grade conduction disturbances after transcatheter aortic valve implantation. Please, Francesco, tell us more about this interesting study.
Okay, well, let me share some slides. Okay, so the background of the study, we know that high-grade AV blocks are still frequent after TAVI, and many of the events happen more than 24 hours after the procedure. So for this reason, many patients, especially in Europe, are discharged more than 24 hours after the procedure. The goal of the study was to identify the predictors of delayed high-grade AV block and to develop a risk score. The endpoint was a high-grade AV block occurring between 24 hours and 30 days after the procedure. We identified derivation cohort of about 900 patients. We excluded the patients who already had a permanent pacemaker, those who developed a high-grade block in the first 24 hours, and we only included patients with 3 ECG, a pre-procedural one, a post-procedural one in the first 4 hours, and a next-day ECG. We identified 7 predictors, which we included in the study. They are use of self-expandable valves, pre-procedural right bundle branch block, new onset of left or right bundle branch block, which persist in next day ECG, implantation depth, PR interval duration before the procedure, and the increase of PR interval in next day ECG. The score showed good performance with an R under the curve of 0.88 in the derivation cohort. In this picture, we can see the distribution of the score in the derivation cohort, and the red line shows the predicted AVB incidence according to the score. According to the predicted risk, we identified 3 risk categories: low risk, with a score of 0 to 3 points, corresponding to predicted risk of less than 2%. Intermediate risk with a score of 4 or 5 points and an expected incidence of 2 to 5%. And finally, high risk patients with a score of 6 or more points and an expected incidence of delayed AVB of 5% or more. We can see that in the derivation cohort, almost half the patients were classified as low risk, with good correspondence between expected and observed risk, and with an incidence of blocks of less than 1% in low-risk patients, and on the other side, an incidence of about 20% in high-risk patients. We validated the score in an external cohort of about 900 patients. The score had a slightly worse but still good performance in this cohort with an R under the curve of 0.80. Again, we see the observed and expected incidence of events are quite similar. And again, we have an incidence of less than 1% in high-risk patients. So finally, we tried to develop an algorithm. The algorithm should be applied 24 hours after the procedure if there was not an high-grade AVB in this period. First, patients who underwent valve-in-valve TAVI with a conventional surgical valve were considered as a low risk, since none of them developed a delayed block and they were not included in the derivation cohort. Then we cannot apply the score in patient in atrial fibrillation, and this is the major limitation of our score. We tried to develop a simplified version, but we decided not to give a cutoff for early discharge. For the other patients, we applied the score, and if the patient is low risk with a score of 3 or less points, we think the patient should be discharged 24 hours after the procedure, since the incidence of delayed block is estimated under 1%. On the other hand, patients who are classified as high risk should remain in the hospital because they have a high incidence of delayed blocks between 8 and 20% in the two cohorts. And for the other patients, the most tricky population, the intermediate risk ones, we observed an incidence of delayed blocks between 1 and 3%, so they could be eligible for next day discharge, but we think we should treat these patients in a different way, maybe with ambulatory ECG monitoring. Okay. Well, Alex.
That's fantastic. It's such a well-conducted study, and probably one, in my mind, the first thing that I would like to know is what was the CT, the analysis of the CT pre-implantation of these patients. What can you tell us? Did you look at it? Is something maybe a sub-study that you can bring on for future indications?
Well, thank you for the question. We know CT variables, in particular membranous septum length, are recognized as predictors of blocks. We did not include CT data for two main reasons. The first, and maybe the more obvious, we did not have CT scans of all patients, and this would have reduced the quality of the study. But on the other hand, including CT variables would make the score less easily applicable. The score can be calculated in 2 minutes. The more difficult variable is implantation depth, which is something which can be measured in 1 minute after the procedure, including variables, in particular measures that are not part of the routine pre-TAVI planning, such as septum length, would make the score less applicable and less standardized.
Yeah, totally. What is also very interesting is that you have such very interesting results, statistical results. The area under the curve is impressive in terms of significance of the statistical results. I was wondering if with the other scores, it could be something similar or not. This is something very interesting. And also, what can you tell us about the valve type and the valve size?
Well, about the valve type, we recognize that the score is particularly robust in two valve platforms, which are Evolut and Sapien, because almost 90% of the total study population were treated with these two platforms. So limitation is that we don't know if the score has similar performance with other valves. There are few more accurate valves in the validation court, about 10-15% of the court, and the score seems to work well also with this valve. But in the future, we hope we will have the opportunity to test the score in a wider population to see if the results are the same. Regarding size, we did not include it as a predictor because we think it's more important the ratio between the size and the annular annular size. And as we already said, we did not have CT data of all patients, so we preferred not to include this variable.
That's right. That's right. I think that new technology in terms of valves, of new kind of valves, could definitely bring something more on the field, because you know, there are different school of thinking about the implantation of a self-expanding valve or balloon expanding valve in a very calcific but not only very calcific valve, but also calcification that are extended on the LVOT. And another very hot topic is bicuspid. Maybe what we can bring to these, bring home from this very interesting study is that we have now a tool that is very easy to use, very friendly in the use, and we can try to maximize the benefit of the patient that we stratify in our population to have a very early discharge. How is the rate of early discharge in your cath lab, in your place?
Well, till now in Bologna, early discharge means 48 hours. Very few patients were discharged until now in first post-procedural day. And we know that if we want to extend the TAVI procedure to many patients, as guidelines tell us to do, we cannot afford to keep a patient in the hospital for 4 or 5 days. So we are starting to discharge patients earlier. We think that in low-risk patients, it's really safe. Less than 1% is really acceptable incidence. We also noted that the symptoms were not very severe. Many patients had asymptomatic blocks or mildly symptomatic. Probably the worst cases are the ones that occur right after the procedure or directly in the cath lab. So delayed blocks probably have a more benign manifestation.
Yes, definitely we need a trial that is perspective, randomized, and maybe with some device that is implanted at the time of the TAVI implantation, or maybe even before, even before, so we can check the possible rhythm disturbance conductions before the TAVI implantation, and then we can have the impact, of course, considering the CT features. Through this, we can go, we can have definitely the best stratification for our patients. What do you think?
Yeah, about the trial, I think we will need a very large population to show a benefit of prolonged or early discharge, because as we see, events are not really common, and strong events are
Even less,
almost
yeah.
zero. And regarding two-step algorithm, this can be useful, maybe more in with the idea of even same-day discharge, which is something that in Europe is still not adopted. We have some data from USA, and for same-day discharge, obviously, pre-procedural estimation of AV blocks is even more useful. While for next day discharge, I think the additional value of next day ECG is something that we should really keep in mind, because we noted that ECG variations that occur after the procedure in the post-procedural ECG but resolved in next day ECG were not predictive of subsequent high-grade AVB. So if the patients have a transient left bundle batch block, this is something we should not worry about.
Totally agree. Totally. So thank you very much, Francesco. Thank you for this before Christmas hot topic talk about one of the probably most interesting and unresolved issue in TAVI. And thank you very much to all of you that follow us in this last episode of the year of EIJ on Air. And we want to see you again the next year. Thank you so much, and have very nice holidays, all of you.
Thank you.
Bye-bye.
Thank you. Bye. And nice holidays to you too.
Bye-bye. Thank you.